Hello everyone, this is Shinya Nakasato from Nclinic and Honmachi Nclinic. Today I would like to talk about what kind of symptoms and imaging findings and what kind of treatment we will perform at our clinic after the diagnosis of knee osteoarthritis, which is very common in the field of orthopedics. There are many different approaches to knee treatment, but we will explain when to use and how to combine options such as rehabilitation, extracorporeal shockwave therapy, PRP therapy, and stem cell therapy. Until now, knee osteoarthritis pain has been said to be mainly caused by pain outside the joints, such as muscles and ligaments, and pain in the joint cavity, such as the meniscus and synovial membrane. Recently, with the development of imaging equipment such as MRI, it has become clear that bone pain is important as a third pain. In particular, the part of the bone under the cartilage called subchondral bone is very important. Subchondral bone is not only the main cause of knee pain, but also nourishes cartilage, absorbs shocks that are not absorbed by cartilage, and is the source of deformity. So the importance of treating subchondral bone has recently been highlighted on a global level. If you compare your knees to plants, sunlight and nutrients in the soil are important for the growth of leaves called cartilage. Leaves grow well only because of the roots in the soil. Subchondral bone is its soil and root part. We treat each of these three causes of pain. Also, if there are multiple causes of pain, each treatment is combined. First of all, regarding extra-articular pain, it mainly deals with tissues outside the joint cavity, such as muscles and ligaments. Even if the muscles are weak or stiff, the burden on the entire joint increases, so rehabilitation is indispensable. Recently, the idea that knee deformity is organ failure caused by metabolic disorders has become common, and the importance of reduced blood flow and metabolic disorders in the entire knee has been observed. As such, it is important to move the knee moderately so that it does not hurt, and rehabilitation is the basic treatment. Next, regarding the pain in the joint cavity, the targets are cartilage, meniscus, and synovial membrane. There are blood vessels on the outside of the meniscus, so repair can be expected. But there are no blood vessels on the inside of the meniscus and cartilage, so synovial nutrition is essential. It is said that stimulating cells in the synovial membrane and cytokines, factors involved in inflammation, helps to improve the environment in the joint cavity. There is a hyaluronic acid injection that is injected into the joint cavity covered by insurance in Japan, but it cannot stimulate the cells in the synovial membrane. Therefore, platelet-rich plasma injections used for PRP therapy and stem cell therapy have been brought into the spotlight. For meniscus injuries, extracorporeal shockwave therapy and PRP therapy have been recognized as effective. If there are many joint effusion, it is effective to target the synovial membrane with APS, or autologous protein solution injections, which have a higher concentration of white blood cells and anti-inflammatory cytokines than conventional PRP injections. Since the continuous accumulation of joint effusion leads to the destruction of articular cartilage, APS, which is effective in improving hydrocele, is effective in improving pain caused by synovitis and preventing the progression of cartilage destruction. If it still does not improve, adipose-derived stem cells are injected into the joint. It has been found that stem cells inserted from the outside work on endogenous stem cells in the synovial membrane to nourish cartilage, repair cartilage tissue, and help chondrocytes proliferate. This is the cell therapy that has been performed in Japan so far. Unfortunately, however, even if PRP and stem cells are injected into the joint cavity, Most of them are absorbed by the synovial membrane, so it is not possible to improve bone pain or the pathology of subchondral bone. This fact is the reason why cell therapy for the knee has been less effective so far. Therefore, it is important to treat the third cause of pain, which is the bone, that is, the subchondral bone. MRI images can be used to find out if there are BMLs, which are bone marrow abnormal lesions. BMLs have been found to be highly correlated with knee pain and progression of disease. We have been using extracorporeal shockwave therapy for these BMLs for more than 5 years and have demonstrated excellent effects. In particular, extracorporeal shockwaves are very effective for BMLs, which is centered on bone marrow edema and can be expected to reduce or cure BMLs. This is a graph that quantifies and represents the change in pain in people who have undergone extracorporeal shockwaves for osteoarthritis of the knee with BMLs. The effect will be visible immediately after irradiation. In a graph that quantified not only pain but also function and ADL, a significant improvement in effect was observed after 3 months. Extracorporeal shockwaves have been shown to destroy pathological nerves in lesions, reduce intramural pressure, reduce BMLs, and eliminate pain. Here is a comparative photo before and after treatment with extracorporeal shockwaves. Before treatment, there is a large black area, a bone marrow lesion. However, after 6 or 12 months of treatment, you can see that it is getting smaller. Bone marrow lesions are related to the progression of joint pain and deformity, so it is better to treat them. In addition, by continuing irradiation for a long time, new blood vessels are induced, and it is recognized not only to improve pathological subchondral bone lesions, but also to regenerate cartilage tissue. These are MRI images of patients who have undergone extracorporeal shockwave therapy for more than 4 years. And you can see that the cartilage layer in the photo on the right is firmer than the photo on the left 2 years ago. It is thought that the cartilage has been regenerated. However, not all BMLs are effectively treated by extracorporeal shockwave therapy. BMLs with bone cysts and osteonecrosis, or subchondral bone plates, in which the plates between the cartilage layer and bone layer are torn, cannot be improved by extracorporeal shockwave treatment alone. This is an MRI image of a bone marrow lesion that was treated with continued extracorporeal shockwaves for a long time, but we could recognize that the BML has not improved due to joint fluid entering through the subchondral bone plate. The subchondral bone plate is the last line of defense between the joint cavity and the bone, and its rupture becomes fatal for the subchondral bone. It is known that when the subchondral bone plate is ruptured, joint fluid enters the bone, leading to bone cysts and osteonecrosis. So, I came up with the idea of inserting stem cells directly into the bone to repair tears in the subchondral plate and to solve the pathologies in the bone that have fallen into necrosis and bone cysts. Overseas, long-term clinical results of PRP and BMAC, in which bone marrow fluid is inserted into the bone marrow, have been published, and the results have been very good, and the number of patients who may undergo joint replacement surgery has been significantly reduced. This treatment, in which our own stem cells are inserted into the bone marrow, is even more powerful and can be expected to produce even better results. In the spring of 2024, Nclinic and Honmachi Nclinic have started injecting a large number of stem cells into the bones of the knee joint. Our clinic is the first facility in Japan to be approved at the outpatient level. By inserting stem cells into the bone, it can be expected that pain will be improved and the pathology of deformity will also be improved. Next, I will explain why they are combined and treated. Most knee osteoarthritis, especially those with a high severity, are in a state of organ failure in which multiple pathologies of extra-articular pathology, intra-articular pathology, and intra-bone pathology overlap, in which case each must be dealt with and must be combined with the aforementioned treatments. Just as photosynthesis from sunlight, carbon dioxide, and nutrients from the soil are all important for plant growth, we believe that it is important to combine treatments to take care of the joint cavity, bones, and areas outside the joint in order to promote healing and prevent failure of the joint. In particular, as the severity of osteoarthritis increases, there is a lot of overlap between these pathologies, and the need to combine intra-articular and intraosseous treatment increases. If there is synovitis or intra-articular effusion that does not improve with intra-articular injection of hyaluronic acid, then APS, autologous protein solution injections, are performed. Since synovitis is often accompanied by BMLs, we would combine APS with extracorporeal shockwave therapy. These are graphs showing the therapeutic effects of extracorporeal shockwaves alone, APS alone, and combined treatment of APS and extracorporeal shockwaves in severe knee osteoarthritis. Up to 3 months later, each has the same effect, but after 6 months, only the effect of the combined treatment is significantly improved. Among the patients who continued extracorporeal shockwave therapy for a long time after APS therapy, there were many cases in which the cartilage layer increased. In fact, a paper announcing these results was published in an international journal. The evidence was widely recognized. On the other hand, especially in patients that have bone marrow lesions with a torn subchondral bone plate, extracorporeal shockwave therapy alone cannot be expected to improve this pathology. In addition, the pathology of synovitis and joint effusion may not improve even with APS therapy. In such cases, stem cells are injected both into the joint cavity and into the bone. These are especially helpful for those who have not reached the appropriate age for artificial joints, or who are unable to undergo surgery due to physical or social reasons. Let's summarize the flow of treatments so far. If you have been diagnosed with knee osteoarthritis, you should first receive intra-articular injections of hyaluronic acid, which is covered by insurance, and rehabilitation. If it is not effective, MRI examination is performed, and if there are bone marrow lesions, the extracorporeal shockwave therapy and hyaluronic acid injections are combined. If they do not improve hydrocele or synovitis, APS therapy is combined with extracorporeal shockwaves. If it still does not heal, or if there is a rupture of the subchondral plate, intra-articular and intraosseous administration of stem cells is performed at the same time. The treatment in which these stem cells are injected into the bone and into the joint at the same time is considered to be treatment that is well worth the price and offers hope to patients who have had no effect with previous stem cell therapy so far. In a sense, it can be said that the lack of effect was due to this combination of methods not being used. We were inspired by the positive results of extracorporeal shockwave therapy for knee osteoarthritis, as well as a combination of APS therapy and extracorporeal shockwave therapy, which we have been working on to date. We are now proceeding with the next phase combination of these therapies, incorporating stem cell injections into the joint and the bone. Additionally, stem cells have a homing effect that accumulates at the site of injury and tries to repair the affected area. Extracorporeal shockwave therapy has the effect of stimulating endogenous stem cells in the synovial membrane and bone to work on tissue repair, but extracorporeal shockwaves also have the effect of enhancing the homing effect of stem cells. If stem cells are injected into both the joint and the bone and combined with extracorporeal shockwave therapy, there is a good chance that it will be a so-called dream treatment to avoid the need for joint replacement surgery for an additional 10 years or more. I am convinced that these combined treatments with extracorporeal shockwave therapy and cell therapy for knee osteoarthritis will make a great step forward in regenerative medicine in Japan and help many patients suffering from knee pain.